So I'm going to start off with this lady. She's an American artist, and she said there's something very specifically traumatic for being told for years and years that your pain is in your head and you're fine, or being told that you need to go into menopause at the age of 20 to treat whatever disease you have. So medical culture and medical knowledge on the whole is failing women with endometriosis and adenomyosis today. So she made this comic, which I'm going to run through, which will ring along the same path that Shravya narrated to you. So, of course, she starts with any typical coming-of-age story for a young woman. 12, she gets her first onset of her first period, okay, and then she realizes that they're quite painful. So this is a very crucial age for adolescents. It becomes very apparent that her periods are not normal. But this is the age when they're very subject to peer pressure, and they start wondering, their friends are breezing through their period, they're not having a problem, but this girl, poor girl, is sitting at home, couched up with a hot water bag and a blanket, and saying, then the self-doubt and fear creeps in, saying, am I normal? Is there something wrong with me? Am I a sissy? All these thoughts creep in. And then the antisocial behavior starts, where they start avoiding school because of the pain. They start avoiding parties, exercise, etc. Although exercise in some cases is known to improve the pain, but a lot of them just kind of, become chronically ill. Then this eventually leads to depression, because this is the age when you're young and you want to go out and you're kind of trapped by your own body at home, right? So while others complained cramps or bloating, these girls have symptoms that progressively worsen. So nausea, vomiting, headaches, blacking out, the dreaded endobelly, which is causing bloating, so they look about 4 months pregnant every time they get their period. Okay? There are many symptoms. We'll go through them in detail. I'm just running through this as part of a story. So when she was 16, her mother took her to the first OBGYN. It's a very typical thing that they immediately put you on suppression, which does nothing to cure the disease. It only treats symptoms. And as soon as that is going away, the worst things that they would do is give hormonal injections, which puts young girls into the state of menopause at the age of 16, 17, 18, 19, 20. And then they're told, this is part of being a woman, this is part of growing into womanhood. Once you get married, all this will sort itself out, and you can have children and blah, 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 and you'll be fine. That's never the story, okay? Then as I get older, my periods become more painful and other seemingly unrelated symptoms arose. So for us as a doctor, the evolution of symptoms and the direction the pain moves gives me a mental image of what areas are affected, which nerves are getting affected, and which structures are getting affected based on what symptomatology my patient gives me. So I'm going to stress on this very importantly, which I tell other doctors also, is listen to your patient. You can't see 20 patients in a day and reach a diagnosis. One consult for me takes 2 hours. Okay, so I can see only about 3 or 4 patients a day. So again, she said 9 or 10 doctors. So this is what happens. These are very typical bad periods happen. Let's induce menopause. Misdiagnosis, it's irritable bowel syndrome. Then there's hormonal treatments, and IUD is what they put into the uterus. It's anxiety, it's in your head, it's your thyroid. So when you get answers like these, obviously, women go into doubt of their medical help and start looking at sources. So I would also say that it's important to be your own advocate. There's great resources available now. There's also a lot of bad resources available, so it's important to look through the data. Okay? Now, as you can see, these are more than just a bad period. There's headaches, migraines, chest pains. There have been cases when the endometriosis invades the diaphragm, which is what separates the chest from the abdomen, which cause lung collapse, hemoptysis, coughing up blood, pain with exercise, painful periods, all pelvic pain, pain shooting down the legs. Sometimes when it invades the kidneys and the ureters, there have been silent kidney loss. I mean, those are extreme cases and are very rare, but you can see it's not just a bad period. Okay? So by the time she was 15, by the time she was 25, she goes through this whole gamut of misdiagnosis and mistreatments, undertreatments, and it's a chronic disease that doesn't kill. It's worse because it kills quality of life. As Shravya very eloquently said, it kills daily. Right? So, then there are many support groups. So this woman had the chance of finding this one very famous book on Facebook called Nancy's Nook for Endometriosis Education. Um, it's, it's a phenomenal database of information. You can go and read there. They have an online database of surgeons and how they're vetted and who is the international list of surgeons and everything you need to know. So whenever I have patients of endometriosis who come in, they're actually better read than a lot of doctors that I've interacted with over the years. Okay? So she had some clarity of, now you've got a diagnosis and how to take it forward. So she had a laparoscopy, which is excision surgery, which is what we advocate to do, excision. So laparoscopy is basically tiny incisions about the size of a fingernail that go into the umbilicus, and we use high-definition cameras, now 3D cameras and 4K, so the technology is always improving, thanks mainly to you all. And this allows you to visualize magnification 40, 50 times the normal, what the eye can see. So we operate with micro-instrumentation, and the important thing is to cut out the disease from the depth. If you visualize endometriosis, it's like an iceberg, so what you can only see is the tip of the iceberg, and the rest of the disease is underneath, which goes and causes all the problems, invades the nerves and the blood vessels and the ureter or whatever it does. So she had her laparoscopy, some amount of clarity, and not even a year out of surgery, she felt like she was reborn, a new life, a new lease on life, so to say. And she says she's very realistic about her journey. She's saying, I know my journey is far from over, but she is miles apart from where she started off at. Okay, I am 1 in 10. The incidence of endometriosis is very important. It's 1 in 10. To put that into perspective, it's the same incidence of diabetes. Everybody here has heard of diabetes, right? No, very few have heard about endometriosis till you saw the flyer that Sravya sent out. Okay, why? It doesn't affect men. So the research money that goes into endometriosis is very low compared to diabetes. It's about here and here. So if you see, can you imagine if men had a condition where they would be crippled in pain every month? It would be there would be a national crisis going on to treat the disease. So we need to work towards addressing women in the first place and listening to our patients before anything further can be done. So now I'm going to come into the data. So what is endometriosis? Endometriosis is the presence of the tissue similar to the lining of the uterus. It is not the same thing, okay? Which comes back to when you go into definitions of what causes it, when we start talking about retrograde menstruation, which means when period blood flows backwards into the uterus, okay, that happens in about 80 to 90% of the women, but that does not cause endometriosis. It's a normal thing to happen, retrograde menstruation. And we said we already affects 1 to 10 women. Now, what causes endometriosis? So the short answer is nobody knows yet. The old answer, which is wrong, is retrograde menstruation, which was hypothesized by this man called Samson. He was a brilliant doctor, but this is where he was wrong. So the new answers, we have what we're looking into currently, the genetic epigenetic theory, where a host of stem cells and cells that would develop similar to an endometrial gland within the abdomen are acted upon by a host of genetic and epigenetic factors and undergo these changes. And another one which was popular by some of the specialists in America was mulariosis, which is basically when a fetus is developing and the organ systems start to take shape. So there are deposits of certain stem cells and endometrial glands along the way in the body, which as puberty and early menstruation begins, is when they start acting, right? So what are the symptoms, okay? They may be asymptomatic, but there are many associated symptoms. Abdominal pain, painful periods, painful sexual intercourse, infertility, fatigue, bloating, pain during ovulation, pain with bowel movements, pain when you urinate, pain in the pelvic region, lower back and or legs, having trouble holding on when the bladder is full, frequent urination, heavy bleeding or irregular periods, silent kidney loss, lung collapse, hemoptysis, which is coughing up blood, and there's many more. Okay, that's just the start of the list. Now, this is commonly misdiagnosed. I'm sure Many people have been told, okay, it's in your head, it's part of being a woman, it's IBS, it's stress, it's depression, period pain is normal, it's PCO, fatigue, thyroid. There's a host of misdiagnosis and correlated symptoms. That doesn't mean that they're not there, but many of these situations coexist. Now, coming to the types of endometriosis, it's not one disease. There are many types of endometriosis. They might all coexist in one patient, or you might have certain permutations and combinations. There's peritoneal endometriosis. Now, the peritoneum is the lining that covers the abdominal cavity. It covers every organ. So when this invades, it goes deeper, and it starts growing in. So then rectovaginal endometriosis, or DIE, or deep infiltrating endometriosis. This is the bad kind of endometriosis, which grows usually in the, between the rectum and the back of the uterus, which I'll explain to you shortly. Then the most common ones, which are easily diagnosed because they're the easiest to see, are the ovarian cysts on ultrasound. And then adenomyosis is slightly related to endometriosis, but it's a different thing. There's endometrial kind of glands within the musculature of the uterus. So this is asterisked because it's endometriosis' evil stepsister. Okay? So it's not endometriosis per se, it's a whole different entity, but it's also considered in our talk. So now just to, I promise this is the only medical picture I've put in this talk, so please hold your lunch, hold your breakfast for now. Okay, so if we look at the top right, this is a normal appearance on laparoscopy. That's the uterus, these are the ovaries, this is the rectum and the sigmoid, and this is the pouch. So this area is where rectovaginal endometriosis grows. Okay, so this area in this normal picture is free. You can fit a fist in there almost. Okay? Coming here, this is stage 4 endometriosis. This is called a frozen pelvis. Okay, both the ovaries are stuck together. Usually they're hanging outside. They've come and gotten stuck together over here. The rectum has gotten stuck to the ovaries over here and the back of the uterus. And there's a nodule which grows up into the vagina and down into the rectum. So depending on how the disease progresses, the symptoms will worsen. And that nodule will also go laterally towards the pelvic side wall where the nerves are, so which will cause pains to shoot down the legs or cause ureteric involvement and eventually lead to the kidney problems. Okay? These are peritoneal implants. So this is the most typical one, what most gynecologists can see and treat. Okay? This is a perfectly normal looking appearance until you go very close, about this close with the laparoscope. So these are called cystic endometriosis, and this may be more painful than this. Okay? There's no relation between degree or stage of endometriosis and symptoms, right? It only becomes surgically difficult how to do it. Now coming to DIE, here's a schematic. So this is, if you look at the side, if you cut your body in half and you're looking from the side, so that's the view, okay? So that's the urinary bladder, that's the uterus with the ovary, that's the rectum. And you can see the implants here on the back of on the front of the rectum and the back of the cervix, on the bladder, on the tubes, on the peritoneum over there. So it's a pretty good picture to show you, to illustrate how endometriosis comes in. Okay, so there's many common presentations that we see is retro cervix, so it just means on the back of the cervix. This is on the back of the vagina. These are the uterosacral ligaments on the side, which are the supports of the uterus. On the vagina, on the bladder, and on the ureters. There are many more areas where it can occur. So on the bowel, the appendix is one of the favorite areas of endometriosis to go. So we just don't look at the pelvis, we have to look at the entire body. Well, the entire abdominal cavity. Yes? Yeah. So it's a section of the body, okay? So if you cut the body from here, down the midline, and you're looking from the side, that's what you see. So this is the front, this is the back, okay? This is the uterus. Sorry, this is the bladder. This is the uterus with the ovary, okay? These brown spots that you see there are what endometriosis looks like. That's a diagrammatic representation. So if there's endometriosis on the bladder, this will cause irritation, so frequent urination. If there's endometriosis here, this will cause painful intercourse, or if it's growing into the rectum, it will cause tenesmus, which is incomplete passing of stools, or pain while passing stools. And if it's on the tubes, it might cause distortion of the tubes. If it grows into the ovary, it forms a cyst. Or if it is a superficial lesion on the ovary, it causes pain during ovulation. So on the 14th day of the cycle, stuff like that. Okay? So how do I diagnose endometriosis? Okay? I listen to my patient. The most important thing, you let the patient talk. Listen to the symptoms. Don't say, okay, I think, she says pain, you don't automatically think endometriosis. You start listening to the symptoms and go into details. See where the disease is taking you. Then, I think I said, a consult takes anywhere between 1.5 to 2 hours. So it's important to give your time to the patient. Okay, then they're coming there to deal with the problem. They've seen 7 to 8 doctors. An average of my patients have had 5 or 6 surgeries before they come to see me. And they've had hysterectomies, they've had their ovaries removed at 25, 30 years of age, okay? And they still have pain, so they come back. So by definition, the disease is outside the uterus. I will come to that in the FAQs, but a hysterectomy is not a cure for endometriosis, okay? So then a detailed history. So you have to go into everything that is done. I go over all the records, all the imaging, what was done in the previous surgeries, what was found there, if they've not had a surgery, what their symptomatology is, what tests have been done, and all that. Then we come to imaging studies. So the most important thing is an ultrasound. Now you have to do an ultrasound yourself as a gynecologist, or you find a good sonologist or a radiologist who is specializing in endometriosis ultrasound. Okay, I had this same patient. This is one of my patients who came to me. This is an ultrasound. So this picture you see on the left is very similar to the cut area I showed you on the DIE image, okay? So this is the uterus, this is the bladder up here, this is the rectum below, okay? Are we understanding? Okay, it's the same thing. This is the uterus, this gray area, okay? This black area here is the bladder, and this is the rectum area. So, I sent this patient to the sonologist, said normal study, nothing wrong. And I did the ultrasound myself. You can see clearly here that there's adenomyosis on the back wall of the uterus, and that adenomyosis has formed a nodule. This whole black area is about a 2 centimeter nodule that has grown into the rectum, and I was explaining her symptoms. So that's why it's very important that a specialist in endometriosis does the diagnosis, and then we also start training other disciplines and other faculties in medicine to identify this. Now, when you suspect digestive symptoms, we also advise an MRI with contrast, which shows bowel involvement. So for you, this picture might be a little easier to diagnose. This is the bladder, this is the uterus, and this is the rectum. And the arrow area is the nodule. So this is the same picture of that, okay? And this is another section, which I'm not going to get into. It's a little more complicated. Now, why are there no blood tests for endometriosis? We always look to see non-invasive techniques to diagnose this, okay? So, peripheral blood is easily obtainable, it's useful, but there's much research going on. So I don't know if many of you followed it, that around April Fool's Day, there was a report that came out that said, oh, there's a blood test for endometriosis now, but it was an animal model, and there's still no conclusive research pool yet, so we are still waiting on that. Maybe it'll happen, maybe we don't know when. Okay, currently, in this day and age, there are no markers to show with sufficient accuracy to replace a diagnosis, nor triage. Although some people would ask for a CA 125 level to be done, it has no good prognostic or diagnostic value. Okay? So, as of today, the gold standard remains laparoscopy to diagnose endometriosis. Okay? Although you cannot say, I'm going to put a laparoscope and by your clinical examination and your ultrasound findings, you should be able to reach a differential diagnosis in your head before the laparoscopy is advised. And when you do a laparoscopy, you can't just go in and diagnose it and say, okay, I'm done, it's endometriosis, and come out. You have to be prepared to go in and treat the disease as well. So you can't, so endometriosis is always a surprise. What you see on ultrasound might be 20% of what you're actually going to deal with laparoscopically. Right? So you always have to be prepared. And what laparoscopy gives you the advantage is the vision, because you see much better. We do near contact, so even subtle lesions are always seen via laparoscopy. And then you use that vision to shape your information, which is going to enhance and homogenize your quality of work, which will allow you to kind of plan your strategy and this thing. But laparoscopy is not easy. There's lots of inconveniences. Okay? There's ergonomy, because where our instruments are fixed in place, so we have to learn. The learning curve is tremendously long compared to open surgery, especially from people who are moving from open surgery into laparoscopy. It's completely different. You can't move your hands very freely. The reduced productivity, which means is my instrument is 5 millimeters, and now we're moving into 3 millimeters. And if I cut with a scissor, I can cut about half a centimeter or 1 centimeter, while if you're doing a laparotomy or an open surgery, you can cut 5. So obviously they're faster. But how you increase speed in laparoscopy is not by being fast. You don't make erratic movements. It's you be very careful and keep your bleeding to a minimum. So we've never had to transfuse blood to a patient who's undergoing a laparoscopy. You reduce blood loss, you'll be very meticulous, you catch every bleeder along the way, and that improves your increases your field of vision and decreases your surgical time by that. And of course, it is tiring, so you can't do 5 cases a day, you can't do 3 cases a day, you can about do 2 cases a day of very difficult endometriosis. Of course, suturing is difficult because we use micro sutures, which are about the breadth of a hair. And energy sources are available, that's constantly improving, that's technology coming in. So training is very important, okay? So who should do the surgery? And this is a big debate. Should gynecologists do it? So people who are laparoscopic surgeons, should they do it? Should the fertility doctors do it? Because fertility is a big question for endometriosis, which is a big peeve with me that I have big arguments with in fertility societies, is that it affects 30% of women have infertility with endometriosis. 80% have pain. They never talk about pain. Like the woman's only job is to bring a baby into the world, and that's it. So should gynecologists do it? Because it involves a lot of retroperitoneal dissection. Endometriosis surgery is harder, more difficult than gynae cancers to do. Okay? So inadequate treatments from experienced laparoscopic surgeons. What's the statistic? So surgeons who are trained in laparoscopy, experienced surgeons, untrained in endometriosis surgery, had recurrence rates between 16% to 35% between 2 to 8 years postoperatively. So should urologists do it? Urologists are very undertrained in laparoscopy, or should general surgeons do it? So this is always a great debate on how to deal with this and who should do the surgery. But the answer is, would you allow a general surgeon to operate on a brain tumor? So obviously not. So the same principle comes into play when you say that a disease that is far more complex than cancer, and if you do cancer surgery, you need to do a 2-year postdoctoral fellowship to be able to do cancer surgery, yet people who are just general OBGYNs are taking on endometriosis cases, and they are doing the best of their own ability, not what is best for their patient. So this is where the thinking needs to be changed, and the training needs to be changed. So post doing a laparoscopy fellowship, there should be a fellowship in specifically in endometriosis. Okay, so this is where we're reaching the era of the laparoscopic pelvic surgeon, which is where you have a high volume center that is doing only endometriosis surgery with a multidisciplinary unit in place. So you need to have your gynecologist excision expert, your ultrasound expert, your fertility specialist, your urologist to deal with the things, the colorectal surgeon who can do laparoscopy, you need physiotherapists, you need pain management specialists, and you need counselors. So it's not the be-all and end-all of it. And of course, it's like a symphony. So we have the endometriosis surgeon is the conductor who's managing all these teams. So eventually, the future model would be to set up these centers in university hospitals to open up referral units for them. So now coming to the FAQs, most common questions that are asked are, do I need a hysterectomy? Will a hysterectomy cure this? So the answer is no. Hysterectomy is not a treatment for endometriosis because if you come to the definition, endometriosis is disease outside the uterus. So why punish the uterus for disease that is outside it? Okay? And if you see the statistics, there are retreatment rates for patients undergoing hysterectomy were 3.5%, 4.5%, and 5.5% in post-op years 2, 5, and 8. So Again, we're almost coming back to 1 in 20 for reoperation rates. Then we come to, do I need IVF? So, excisional surgery allows conception rates of 80% within the first year after surgery. Okay? Out of these 80%, 60% conceive naturally. So there's no problem with her ovulation. The problem is on the path there, and the disease that is distorting the anatomy. Once you restore the anatomy, then 60% will conceive naturally. And the other 20% will, other 40% of those 80% will require an assisted reproductive technique for their outcome. Okay? So this was a study by a good endometriosis surgeon from Rouen in France. And why medical therapy fails? Okay? Because pharmacology, pharmaceutical will always push medicine first, which has been wrongly taught in our schools as well. So no medicine eradicates endometriosis. I said it treats symptoms, it suppresses symptoms, but it does nothing for the disease. As soon as you take away the medication, the disease comes back with a vengeance. Medicines are designed only to treat symptoms. Currently, surgery is the best treatment for endometriosis. We need research to find better treatments, but as of now, the mainstay treatment is excision. It's the only surgery that can treat superficial and deep disease anywhere in the body. Medication has side effects, okay? Coming to hormonal medications that may induce early menopause, depression, blindness, bone loss, hot flashes, insomnia, night sweats, and many, many more side effects. So I wouldn't recommend putting a young girl or even an older lady on these kind of things unless absolutely, absolutely necessary. Does pregnancy cure endometriosis? Big question. Now, I hope that I'm not wrong in my assumption that this myth is being dispelled, is slowly disappearing, and the reality is that pregnancy, like hormonal drug treatment, so pregnancy is exactly what hormonal therapy does. It's simulating, it's taking away the effect of the hormones. So it may temporarily suppress the symptoms, but it does complicate pregnancies. There have been cases where the endometriosis, the pregnancy has grown through the endometriosis and caused bleeding in the abdomen, which is an emergency, which required emergency surgery. And we all know that emergency surgery never ends as well as elective surgeries. Therefore, symptoms usually recur even after the birth of the child. So we always end up going full circle in medicine, I feel, that what is old becomes new and what is new becomes old. So if you see our own text from Sushruta Samhita, that says surgery has the advantage of producing instantaneous effects, hence it is the highest value of all the medical tantras. This was in 800 BC, and we're in the 21st century now, so we have come full circle or not. So we come back to why have we failed women, as doctors. So it comes back to your training. In medical school, you open a medical textbook, the definition of endometriosis is wrong, the cause of endometriosis is wrong, the treatments for endometriosis are wrong. They say first line of treatments is give medication and painkillers. Time to diagnosis from onset of symptoms is anywhere between 7 to 12 years. Okay, depending on what country you're in. If you have to go in the Western world, if you have to go through a GP and get referred, it takes longer. Okay. Among OBGYs, suppression is the first line. That's what has been taught and still perpetuates. The head of one of the gynae endoscopy societies, the laparoscopic societies, said there is no role for surgical treatment of endometriosis. She said this in a keynote lecture. So you can imagine what damage is being done today in our modern medicine. No training curriculum for laparoscopy in postgraduate training, and there is no training curriculum in the whole country for excisional surgery. Right? So women are told to just get pregnant. This is where we have a big problem. And we need to identify that women are not vessels to bring babies into the world. Women are future CEOs, bosses, surgeons, anesthetists, professors. They have an equal say everywhere. And they are not just going to be wombs. There's more to a woman than a womb. So what I attempted to do was we started an Endometriosis Centre to bring awareness. Because India has no credible educational resources on this disease. So I started the Indian Centre for Endometriosis. We have affiliations with hospitals in South Bombay and Hyderabad as of now. Hopefully to reach the other metros soon. So it's basically to create patient awareness. Our goals are to create awareness about the disease, educate women and physicians about early diagnosis and correct treatments. Now also to reach out, allow women to come in and treat each case. So every case is unique, and the treatments have to be tailored to that individual case. It's not one size fits all. So their particular patients have disease and expectations and goals of their treatment, and you have to sit and accustom or tailor the radicality of your treatment to that. So coming back to listening to your patient, so you have to sit with your patient and go through all of this. So that is what we're trying to teach physicians as well. And future steps, of course, if this grows, I feel it should be handed over to a network of endometriosis warriors, and it should not be in the hands of physicians, because that will remove some element of bias that comes in. And like I said, women need to be their own advocates for their own treatments and identify that. So eventually my long-term plan is to hand over ICE to a network of endometriosis warriors, and I can focus on more interesting things like being in the OR. Like, I'm sure you all love to be in your labs and not here listening to me. And future plans would be to set up resources to get into research. Obviously, we have a long way to go, and we do need to divert a lot of our resources into research, not just surgical or medical treatments. Okay, I'm going to now thank you for your time and open the floor to questions.